Good morning, everybody. Today we will talk about acute and chronic rhinosinusitis. So, as the name suggests, rhinitis. Rhinitis is the term which is used to define infection and inflammation of the nasal mucosa. So, rhinitis is clinically defined as the inflammation of the lining of the nose characterized by one or more of the following symptoms, which is nasal blockage, anterior or posterior rhinorrhea, sneezing, and or itching of nose during 2 or 3 consecutive days for more than 1 hour on most days. That means the person is having itching or sneezing or both for more than an hour for 2 to 3 days continuously. So, clinically, there is inflammation of the lining of the nose. The lining of the nose is made by ciliated columnar epithelium, which get inflamed, and there will be more of secretion, ultimately leading to for having edema and secretions. So, forming having anterior rhinorrhea, that will further lead to posterior rhinorrhea or and also nasal blockage. In the diagram, we can see how the picture of the rhinitis will look from the normal picture. The turbinates are hypertrophied edematous, and also they are covered with mucus secretion or mucopurulent secretion depending upon the infection of the ear, of the nose. So the rhinitis is usually classified as allergic and non-allergic. So allergic are those which elicits allergic reaction and have a IgE mediated course of action, and rest of other rhinitis are known as non-allergic rhinitis, that are vasomotor rhinitis or fungal sinus allergic fungal sinusitis, not allergic but fungal sinusitis like mucor and other. Similarly, it can also be classified on the basis of duration. It can be acute or it can be chronic. So acute is short duration, usually caused by bacteria and virus. Long duration usually have accompanied chronic sinusitis, that is inflammation of the lining of the sinuses. In acute, it is said to be less than 3 months of duration. Normally, it is 12 weeks or 3 months. In chronic, it is more than 3 months, that is more than 12 months of uh, infection. So, as the disease progresses, the signs and symptoms also uh, get altered. So, in acute, we have more in acute bacterial and viral rhinitis. We have an common cold-like symptoms like more of a rhinorrhea, more of a inflammation of the mucosa. But as the rhinitis progresses towards the chronic side, the symptoms also change according to the duration. That is, the changes in the mucosa are more definitive in the chronic case as compared to in acute cases. So in acute cases, it is usually, as I told you before, it is usually by bacteria or it is usually by virus. But the symptoms are like common cold, like sneezing, watery discharge from nose, nasal blockage, headache. So these are all the common symptoms which we get in this acute rhinitis. And normally it is caused by rhinovirus, or it can be caused by influenza virus, adeno and echovirus. But rhinovirus is the most common virus which causes the acute rhinitis. The bacterial causes includes Staphylococcus pneumoniae, Haemophilus influenza, Moraxella catarrhis. So, in bacterial causes, the person will have purulent discharge, mucopurulent discharge from nose. The person will have hyperemia or sneezing and nasal blockage, or rest of the symptom is the viral ones. But the discharge quality will change from mucoid, watery mucoid to mucopurulent. So, what are the predisposing factors for acute rhinosinusitis? First is climate, second is overcrowding, third is the immunity status of the patient, nutritional deficiency, lack of sleep and fatigue, and nasal obstruction. Climate is one of the major factors affecting the environment of the person. So, usually in rainy season or when there is change in the climate, these are the times when the person usually develop rhinitis. Similarly, overcrowding will lead to multiple factors, like the source of infection will increase as the in overcrowded space there is higher chances of infection to get to the patient. And also overcrowding causes increased uh, uh, hyperemia of the nasal cavity. So the person can easily get nasal obstruction, headache. Similarly, immune status of the patient. If the person is immunocompromised, the person have low immunity, then the person can easily get infection from the normal air also, as the person is immunocompromised. In fungal sinusitis or fungal rhinitis, we can see these things. Also remember that the immune status is compromised. It can be due to serious infection like AIDS, or it can be due to chronic disease like diabetes. So, immune status is also a predisposing factor. Similarly, nutritional deficiency, as the deficiency of micronutrients and other major protein also can lead to immunodeficiency in the patient. So indirectly leads to the higher chances of infection in the patient. Lack of sleep and fatigue, these two causes delayed immune response or decreased immunity of the patient, ultimately leading to uh, infection. Nasal obstruction. Nasal obstruction is usually caused by deviated nasal septum, nasal mass, or it can be due to foreign body. So, due to nasal obstruction, there will be stasis of the mucoid secretion, which is a source of cleaning for the nasal cavity. If there will be stasis, then ultimately in stasis of this mucoid secretion, this will lead to a growth medium for the bacteria, as the air is inhaled through nasal cavity and is filtered in the nasal cavity. So the filtered material will be accumulated over there. That filter material may contain bacteria, may contain virus. So this material will be having a acting as a culture medium. So nasal obstruction will also lead to rhinitis. So what is the pathology for development of rhinitis? When there is infection, initially there is vasoconstriction. For short duration, after that, the there will be reflex vasodilation due to accumulation of the metabolic product in the nasal cavity. This will lead to reflux vasodilation, and this vasodilation will be more as compared to normal vasodilation, because it's not due to requirement of oxygen or requirement of nutrients, but it's due to removal of the waste product accumulated due to the initial vasoconstriction. So there will be high chances of hyperemia, high chances of blood flow to the nasal cavity. Also remember that the nasal mucosa is highly vascular. Nasal turbinates and all the mucosa is highly vascular. So there will be mucosal edema due to reflux vasodilation. Ultimately, this edema will lead to decrease in the cavity size and causing obstruction. So the patient will develop nasal obstruction. As this nasal obstruction will be there, that I have just told you in the last slide, that when there will be obstruction, there will be stasis of the discharge. So the discharge will be accumulated, and this discharge will come out from anterior nasal nares. So anterior rhinorrhea can occur, or it can move posteriorly, and if it comes from posterior nares, there will be posterior rhinorrhea. Also remember, this discharge will also act as a growth medium for the bacteria and the viruses, which can accumulate easily in this medium. So clinical features are ischemic stage, as there will be initial vasoconstriction. There will be the patient will complain of itching in nose, drying of the nose. Person will complain of fever and body ache. So these are the very initial symptoms a patient comes with the acute rhinitis case. Then after that, the patient develops vasodilation. So vasodilation stage. Here the patient will have running nose as the blood supply to the mucosa is restored and there is vasodilation. So the mucus secretion is improved. So the patient develop running nose. There will post nasal drip, that is large amount of discharge which is been formed is drained posteriorly. Normally the flow of the mucus is posteriorly. So if the amount of discharge is increased, the person will develop post nasal drip. Also remember, this post nasal drip will always cause irritation in the posterior nasopharynx and oropharynx. The patient may develop cough. So there is high chances that patient will develop coughing after this. So after uh, few days or uh, after few hours, like 20 to 24 hours, there will be ciliary paralysis, and the mucus will be becoming thick and viscid secretion, and this thick and viscid secretion will have uh, will act as a culture medium for the bacteria. So secondary bacterial infection will occur in this medium. So as I've told you, stasis will occur, and this stasis will lead to development of a thick viscid secretion. This thick viscid secretion, on this secretion there will be secondary bacterial infection, and the person will get bacterial rhinitis. Now, as the ciliary function improves automatically after few hours or days, the stage of resolution will start, and as the mucus which has been collected in, or the secretion which are collected, that is removed from over the nasal mucosa, the symptoms of the patient will subside, and the ciliary function improves, and the edema will subside. After that, Obviously, if the edema will subside, the nasal blockage will be removed and the other symptoms will be subsided subsequently. Now, what are the complications of rhinitis? First is pharyngitis, second is sinusitis, third is otitis media, fourth is tonsillitis, and fifth is lower respiratory tract infection. As I've told you, the secretion normally clears from posterior nares. So, the infection which is present in the nasal cavity will migrate posteriorly to the nasopharynx and ultimately to oropharynx and other, that is the laryngopharynx. So, the infection will travel from nasal cavity to the pharynx. So, patient may develop pharyngitis after rhinitis. Similarly, the nasal cavity is also connected with the sinuses, that are the maxillary sinus, the ethmoid sinus, the frontal, and the sphenoid. So, normally the sinuses are secreting mucosa from the cavity to the from the sinus cavity to the nasal cavity, but in cases of rhinitis, there is inflammation or edema of the nasal mucosa. So, the patient will have obstruction in the flow of the secretion of the sinuses too. So, this will also lead to accumulation of the secretion in the sinuses, ultimately leading to the infection in the sinuses and developing sinusitis. So, normally recurrent acute infection of the nasal cavity generally lead to development of chronic rhinosinusitis. So, sinusitis is a complication of a acute sinusitis. Similarly, as we know, the eustachian tube opens in the nasopharynx posteriorly, that is present just posterior to the posterior nares. So, the infection from the nasal cavity may ascend to the middle ear cavity and cause otitis media. It can be acute, it can be chronic, depending upon the duration of the infection. Similarly, as I have told you that the secretions are going backward to the nasopharynx and oropharynx. So the secretion will be touching the cavity, the lining of the pharynx. So the mucosa associated lymphoid tissue, that is forming the Walder's ring, that will be affected, and there will be enlargement of the tonsil. It can be enlargement of nasopharyngeal tonsils causing adenoid hypertrophy, or it can be um, enlargement of tubal tonsil, or it can be enlargement of pharyngeal tonsil. So the person can get tonsillitis secondary to rhinitis. Similarly, if infection travels to the lower respiratory tract, normally the secretions from the pharynx goes to the esophagus, but there are chances that the infection or the infective material goes to the respiratory tract. This may lead to lower respiratory tract infection, which is a known complication for rhinitis. So, what is the treatment of choice? In acute rhinitis, first the patient should be given rest, systemic and local decongestant. So, rest is requirement because the immunity of the patient will improve when the person get the rest, and hydration should be maintained along with the all the micronutrients. So, the patient is given adequate hydration along with the fresh vegetables or fruits so that the nutritional value of the patient improves. As I have told you, the predisposing factors, we should remove those factors like the overexertion or lack of sleep or overcrowding. We should rule out those points also. So first of all, the person should be given rest, should be maintaining good hydration along with nutritional food. Then comes the medical treatment, which is systemic and local decongestant. Systemic decongestant are antihistaminics. Local decongestant are oxymetazoline, xylometazoline, which are nowadays easily available. After that, the patient develops headache or the uh, um, associated symptoms. So we treat the associated symptoms by giving analgesic. We can give paracetamol as an analgesic. We can give NSAIDs as an analgesic, and also in patients in which these drugs can't be given, we can give opioids like which are no, opioids as an analgesic. Now, steam inhalation is also given as steam normally act as a mucolytic agent and the viscosity of the mucus is reduced. So, the clearance of the mucus will cause less stasis and the clearance of the bacterial and viral load. Also, steam inhalation have a soothing effect on the nasal cavity along with the pharynx. Now, if these all are a common line of treatment for viral and bacterial rhinitis, but in cases, so this was the common treatment for viral as well as the bacterial rhinitis. But in bacterial rhinitis, you have to give or you have to start antibiotics for the control of the bacterial proliferation. Also remember, in patients with rhinitis with secondary or having a secondary bacterial infection also, you should start antibiotic. It is advised to start empirically a antibiotic because normally viral rhinitis is followed by a bacterial rhinitis. Now we will talk about some rhinitis, some types of rhinitis due to other causes in short. First is influenza rhinitis, that is an infection of upper respiratory tract infection by influenza virus A, B, or C. It is pathophysiologically there is necrosis of ciliated epithelium followed by bacterial infection. So, clinical features of the rhinitis is same, but it is severe as in acute rhinitis. Also, there will be generalized weakness along with severe joint pain. So, for the investigation to be done in this specific type of rhinitis, suspected rhinitis is acute, antiviral titers. So, the complications can be acute respiratory infection. The person may develop pneumonia or secondary bacterial infection in the lower respiratory tract followed by the leading by the complication. So the treatment is amended in 200 milligram per once a day. Along with that, we have to give antibiotic empirically and supportive treatment. The supportive treatment includes paracetamol, multivitamin, along with that nasal and systemic decongestant. Also, vaccine is available in market which can help in the reducing the symptoms or the severity of the disease along with reducing the chances of infection too. The vaccine is Influvac by the name of Influvac. So this is an influenza rhinitis in short. There is diphtheric rhinitis also. It is caused by Corynebacterium diphtheriae. These patients are usually carriers. There is a grayish white membrane covering over the nasal septum, floor, and the inferior turbinate. That is the medial part of the nasal cavity along with the lower part. Also remember the patient develops fever, joint pain, thick purulent nasal discharge which is easily removed, and also the membrane can be removed easily. So removal of the membrane easily is pathognomic of Corynebacterial diphtheria infection or diphtheric rhinitis. So the investigation are nasal swab. You get a Chinese letter pattern in the microscopic examination. Also CBC, X-ray PNS, there will be changes. So the treatment is, as this is a diphtheric infection, anti-diphtheric serum is given, or it is at 100% advised to give anti-diphtheric serum. Along with that, the patient is isolated, and as the disease it will resolve, and but it is seen that the person usually becomes a carrier. That is, the symptoms will subside, and so this was the diphtheric rhinitis in short. The other is chronic simple rhinitis. That is the infection which is for longer duration. That is the patient have more than 12 weeks or 3 months of infection of nasal cavity. The patient complains of uh, long duration of infection of the nasal cavity, or then similar complaints of acute rhinitis recurrent for long period of time. Then the patient is diagnosed as chronic rhinitis. So an advanced stage of unresolved acute rhinitis due to predisposing factors like nasal obstruction, vasomotor metabolic disorder, infection in neighboring areas, that is the sinuses are infected or tonsils are infected, patient may develop rhinitis chronically. So there is chronic hyperemia, that is engorgement of turbinate and loss of cilia along with globulate cells. So these both changes, that is loss of the cilia and globulate cells, may be reversible, but normally if there is loss of cilia and globulate cells, cilia is required for the clearance of the mucus secretion. So there will be stasis. Secondary, there is loss of globulate cells which are required for the production of the mucus. So the production is also reduced. So ultimately there will be formation of crust in the nasal cavity. So the person will develop nasal obstruction along with nasal discharge, headache, anosmia, and postnasal discharge. Nasal obstruction, similarly to the acute rhinitis, there will be um, hyperemia, edema, and leading to nasal obstruction. Also remember, there is loss of globulate cells, and nasal secretion clearance is also reduced because of loss of cilia. So there will be formation of crust in the nasal cavity. This will also add to nasal obstruction. This stasis of the mucosa, this stasis of the mucus over the mucosa for long time causes development of nasal discharge. This nasal discharge will also cause obstruction of various sinuses. So ultimately there will be headache. Also remember, for the sense of smell, the chemicals need to be dissolved in the nasal mucus. So if there is less mucus formation, the patient will develop anosmia. Similarly, post-nasal discharge will be thick and also viscid. Clinical feature will be mucosal edema, septum will be congested, velvety, middle terminate enlargement, secretion on the floor of the nose. On investigation, we will go for X-ray PNS. We may go for CT PNS as we will require further treatment, but initially we will go for X-ray PNS. Now the treatment will be correction of the predisposing factor. We will give antibiotic, we will give saline wash, topical steroid, decongestant, and the decongestant will be systemic as well as topical. Chronic hypertrophic rhinitis. In advanced stages of inadequately treated SCR with irreversible mucosal and submucosal changes, the patient is known for chronic hypertrophic rhinitis. In this pathogenesis, the pathogenesis of CHR is mucosal and submucosal thickening and permanent hypertrophic changes occur in the submucosal layers leading to thick nodular mucosal fibrosis. This fibrosis on examination or on anterior rhinoscopy, the turbinates appear to be hypertrophied, so the name suggests chronic hypertrophic rhinitis. The clinical features of this disease are there is circumscribed or the localized, as I have told you, thick nodular mucosal fibrosis. So there is specifically circumscribed hypertrophy of inferior turbinate with papillary surface. Middle turbinate is dull with polypoidal changes. Mulberry enlargement of the posterior end of inferior turbinate. So these all are the changes in the nasal cavity in chronic hypertrophic rhinitis. This is a typical picture which we will see on endoscopy of a patient of a chronic hypertrophic rhinitis. This is the inferior turbinate and this is the septum. We can see there is a nodular hypertrophy of the turbinate obstructing most of the nasal cavity. We can't even see the middle turbinate. Investigation or to be done in cases of chronic hypertrophic rhinitis are nasal endoscopy, that is diagnostic nasal endoscopy along with X-ray PNS, and also we will do CT PNS as the treatment progresses. Now the treatment of this disease is first removal of the predisposing factors. Then we, as I've told you, irreversible changes have occurred in the mucosa and submucosa of the turbinates. So we need to remove those parts which are pathology or the submucosal layer which is hypertrophied. So electric cauterization of the turbinates are done. Submucosal diathermy of inferior turbinate is done. Laser and cryosurgery for removal of inferior turbinate is done. Surgical trimming using scissors or the cold instrument is done. Turbinoplasty with microdebrider is done. Ultimately, the aim of the all this procedure is to reduce the size of the inferior turbinate so that there is less nasal obstruction and the air can freely float from anterior cavity to the posterior nares, anterior nares to the posterior nares. Now, this is a picture of a turbinate showing mulberry appearance. शहतूत जो बोलते हैं, that is mulberry. So the mucosa over the inferior turbinate appears like mulberry. And in the second diagram, we can see the posterior end of the inferior turbinate. This is the second picture is of posterior rhinoscopy. We are seeing the posterior nares. This is the septum in between and the posterior end of the inferior turbinate. Also, we can see opening of eustachian tube. Now, one of the type of rhinitis is rhinitis sicca. It is seen in farmers, minor exposed to dry and dusty atmosphere. So, presence of a dirty black crust formation in anterior part of the nasal cavity is typically seen in rhinitis sicca. The pathogenesis of this disease is there is squamous metaplasia of ciliated columnar epithelium. That is, the ciliated columnar epithelium is replaced by squamous epithelium, which is ultimately leading to glandular fibrosis. Thick viscid mucus blanket is formed over the nasal cavity, nasal mucosa, and this secretion will lead to crust formation, and ultimately there will be bleeding and excoriation over the septum, and in advanced cases you may get perforation in the anterior part of the septum. So for the treatment we give a saline wash along with 25% glucose and glycerin drops, and also change of the environment. That is, the farmers are advised to avoid hot, dry, dusty atmosphere along with miners, so that there will be natural recovery in the nasal cavity. This is a typical picture of the rhinitis sicca. There is thick viscid mucus crusting over the septum and the turbinate, typically anterior part of the turbinate. We can't see the blackish part, but we can see some part anteriorly which is black in color along with blood stain. One of the rhinitis is rhinitis medicamentosa. It is the condition in which there is prolonged use of local nasal decongestant like xylometazoline. So the patient, when they are using local nasal decongestant for long duration, nowadays on TV we get ad of a spray, use the spray and the nasal cavity will open, and those ads lead to purchase of those drugs, that is xylometazoline and oxymetazoline, from the medical over the counter, which should be stopped in few days. Those drugs are taken by the patient directly without advice of the doctor for long duration, and as the time duration increases, the person develops tachyphylaxis to the drug, and there will be reflux hyperemia of the cavity, ultimately causing edema in the mucosa and causing uh, nasal obstruction, which is not relieved by any decongestant given locally. So, in pathogenesis, vasoconstriction in ischemia caused due to nasal decongestant for long duration. After that, there will be reflux vasodilatation. As I explained this pathogenesis in previous diseases also, reflux vasodilatation is more severe vasodilatation as compared to normal vasodilatation. So, rebound congestion is more. This will lead to nasal obstruction, and this nasal obstruction will cause the patient complain of nasal obstruction, and the patient will go and have more decongestant. So, repeated use of decongestant reduces the effect of decongestion. So, the patient will cause tachyphylaxis, that is, the patient will develop resistance to the drug, and ultimately, due to the loss of ultra adrenergic tone and desensitization of mucosa, this will lead to वो बार बार स्प्रे डालेगा, बट देर विल बी नो vasoconstriction. The nasal cavity will not open even after using any amount of xylometazoline or oxymetazoline. So for this, we will have to the person will now we will talk about the symptoms. The symptoms are nasal obstruction, worsening at night, and headache. Signs is diffuse papillary hypertrophy of the anterior end of the inferior turbinate, mulberry hypertrophy of the posterior end of the inferior turbinate. Investigation is endoscopy of nasal cavity. Here we can see both the anterior and the posterior end of inferior turbinate, and along with that the mucosa of the nasal cavity too. Now the treatment is discontinue the nasal decongestant using. The person which always take the history of use of decongestant in complaint of nasal obstruction, if he is using nasal decongestant, stop the nasal decongestant. Then topical steroid and saline spray is started, and it is continued. Normally, on this medical management, the patient improves, and there will be no further treatment required. But in some cases, the obstruction is so severe that that is not recovered even after giving steroid and saline. So we will go for operative procedure for surgical reduction of the inferior turbinate. This is all for rhinitis, that is acute and chronic rhinitis, and some of the few types of the rhinitis, that is rhinitis medicamentosa, rhinitis siccata, influenzaal rhinitis, diphtheric rhinitis. These are all types of rhinitis in short. Thank you.